before you can stabilize them. Some of that will come with in hospital work and admitting them and putting them on insulin drips. That's kind of different. But you need to have some idea of the basic concepts. If you see them in practice, you need to have some idea of what to do to modify a regimen if needed. So any questions here? I don't mind going back over it. Okay, then let's start on page 6. So if you make adjustments, you're going to make adjustments based on their blood sugar response. So when they come back, you're going to look to see is what you've done effective. So how could you tell, what kinds of things could you do to the patient besides of looking at their blood sugars? What else could you look at to say that things are heading in the right direction? You've reversed this metabolic machinery, and you're moving them more to where they can use the fuel that they are taking in. What could you do?
Use the history, see how they've been feeling.
Okay, and in terms of how they're feeling, what would you ask them about?
Are you feeling less fatigued? How often are you urinating? How much water are you drinking? Are you guys thirsty? Things like that.
Perfect. So you're going to go back and look at energy levels should go up. Their urination should go down, thirst should be better. The thing I usually pinpoint the most is how often are you getting up at night? Like, can you remember how many times you went to the bathroom yesterday? Anybody remember how many times you went and peed? Can you remember how many times you got up last night and went to pee? Yes. So you can remember what disturbs your sleep. So I usually will focus on there. How often are you getting up and going at night? Now, if they're going every 15 minutes or 30 minutes, they'll remember that. They can tell you that. Okay. What else did you say? Urination, thirst, how they feel. Okay. What else could you do?
Weight gain.
Weight. Perfect. So you want their weight to either start going up or at least have stabilized. And in 3 days it may not do that. You at least want them to not losing weight. But it'll start going up pretty quick. What else could you look at?
Hunger?
Okay, hunger. Their appetite should become more normalized. They should not be as hungry. So you check blood sugar, you'd also look at what their log was. So you're going to be looking at pre-meal, and their pre-meal goal is what? 80 to 130. You may not even be that strict in the beginning, but you want to see a change. Then you're going to change the basal or the bolus based on that. You may not do it, but you may have the dietitian look at their carb record. And if they've had lows, you really want to pay attention to that. Did they recognize it? How did they treat it? How did they feel? Okay, so changing one component at a time. So usually, and usually you're going to make very small changes. So type 1's, a unit is huge. A unit with a type 2 is nothing. But a unit with the type 1 is big. So you're usually going to be making, I try to make changes of 10% or less. If all their blood sugars across the board are high, I'll usually change the bolus first. Sorry, basal first. If they're having one meal in a day, one spike in a day, then I might adjust that. But the change is going to be one or the other. Looking at insulin timing, we've talked about that. We've talked about using that, how soon they, or how far before a meal they inject to also control blood sugar. So if their blood sugar is a little bit higher than normal, they could always inject a little bit longer before they ate, giving the insulin time to work. In terms of if they're having lows, I never have them eat to match the insulin. Okay. So if they had a low, I'm going to reduce the insulin, I'm not gonna increase the amount of carbs they eat. See the difference? If you start doing that, they'll put on weight, and it's not the right way. When they adjusted your insulin, can you remember how they went about that?
I don't remember exactly. I know I had to keep a log, so she would see where I was going on with. I don't remember the adjustments exactly.
Contraindications to intensive insulin therapy. So the intensive insulin therapy, 3 or more injections a day. So the first one is hypoglycemic unawareness. Michaela mentioned some of that. As people progress in their type 1, usually at about 15 years, most of them will have what we call hypoglycemic unawareness. So the epinephrine release in response to a low is usually absent at that point. The more lows people have, the sooner or the more quickly they'll get to that hypoglycemic unawareness. If they have a profound or severe low, they may go weeks or months before that process returns, or before that those symptoms come back when they have a low. So that's why being sure that keeping them out of severe lows, keeping them monitoring will help. So we would not do that with someone who had hypoglycemic unawareness. Counter-regulatory unresponsiveness. So glucagon, they say glucagon responsiveness to hypoglycemia goes away after about 5 years. This doesn't happen to everybody. This is kind of average. The poorer the control, the worse those counter-regulatory hormones behave. The very, very young and the very, very old, we don't put them on it because of the risk for hypoglycemia. Medical reasons, are they debilitated, short life expectancy, a malignancy? We wouldn't put them on it. We would raise our glycemic goals and keep them out of hypoglycemia. Questions about that? Okay, the first blood sugar of the morning is really important. It kind of sets the stage of the day. It also tells us what happened overnight when they weren't eating. So look at those reasons on the very top of the page 7. This goes for type 2s as well. If someone comes in with a high in the morning, these are the things I'm looking at. Often it is what they ate the night before. Okay? If they went to bed and they ate a lot of grapes, they drank juice, they had milk, they had a sandwich, they had something with a lot of carbs in it, often their morning sugars are going to be high. So if that's something that they want to keep doing, then you may need to look at covering it with insulin or modify what they're eating at bedtime. Or do they really need a snack at bedtime? Oh, the first thing I always ask them is, are you hungry? Really? Hungry? And if they're telling me yes, then I may be looking as, are you getting too low before you go to bed and this is your response? Have we given you too much insulin at supper, which has driven that blood sugar down? Are you worried about getting too low at night, and so you're overeating before you go to bed? So trying to figure out what that intake and the reason why. If they are, let's say they take their basal in the morning, it may be that by the next morning that dose has attenuated, so it's fallen off. So Tresiba is probably the only insulin out there that truly, for almost everybody, would be at least 24 hours. With Lantus, it's plus or minus, it's 22 hours plus or minus 4. So you could have people who are 18-hour Lantus. And so if they're taking it in the morning, by the time they get to the next morning, they've fallen off. So there's not enough insulin in the morning to manage blood sugars. So that's another reason, looking at what insulin is active and has it attenuated. If they skip the dose of insulin the night before, this is common with type 2. I fell asleep, I forgot. That's a lot of times why I don't like to put insulin at night. It's so often skipped by especially older folks and the type 2s. But if it's working, it's a fine place to leave it. there's two phenomenons. There's one called the dawn phenomenon. Dawn phenomenon happens to everybody. Every one of you have this. So it's the diurnal variation of hormonal release. So about 2, 3 o'clock in the morning, all kinds of hormones start to be released, and they rise until you get up and they get you ready to get up in the morning. Cortisol levels rise, catecholamine levels rise, blood sugar rises. When you get up, your blood sugar is normal because you can produce enough insulin to cover it. But people with diabetes don't necessarily have enough insulin on board in the early hours in order to suppress that. So we call that dawn phenomenon. I see it often in type 2s, and here's the pattern. They're high in the morning, and then the rest of the day they're pretty normal. So that glucose, that rise, but also the hepatic glucose output overnight is too high for them, and so they wake up with high fasting blood sugars.
Someone with a regular sleep schedule, is that reversed, is that even there?
I don't know.
Okay.
You got me. I'm not sure. So he's asking if you're a shift worker or you work nights and you sleep through the day. Does that happen? I don't know. Okay, so that picture at the bottom kind of shows you the dawn phenomenon, that rise in blood sugar early hours to the first thing in the morning. So it's important to ask those questions to address. The other thing I do is I ask them if they had a low overnight. So the phenomenon on the next page is called the Somogyi phenomenon. Some people believe it does not, don't believe it exists. I think it does. And what the Somogyi is a reactive hyperglycemia to a hypoglycemic event in the middle of the night. So let's say your blood sugar goes down low enough to evoke a counter-regulatory response, but not low enough that it wakes you up. But the liver can respond. Then in the next morning, your blood sugars may be higher. I often see this if I keep raising the blood sugar, the insulin levels at night. Their blood sugars in the morning get higher and higher and higher. So they're dipping down, and then their counter-regulatory response is raising them up too high the next morning. Have you ever experienced that?
Yeah, I had to go to the doctor about this because I was like, I go to bed and my blood sugar is like 90. I wake up and it's 200, and I said, pretty sure I'm not sleepwalking and eating at night. So why is it so high in the morning? And they thought it was due to this phenomenon, which they never said. But when I got the sensor, we could see I was dropping while I was sleeping, but not waking up.
Mm-hmm.
And then in the morning, it was like correcting itself by going high.
So I always ask questions about if they're high. So I look at their nighttime, just like she has said. I'll look at nighttime. Well, you're going to bed pretty good, but you're always waking up higher. So I always ask about low blood sugars at night. Okay. Low blood sugars at night tend to manifest themselves a little bit differently. Sometimes it's the partner that is sleeping with them saying they are really restless in the middle of the night. Or I'll tell people, or people will tell me, my cat gets on my chest and it goes trying to wake me up. So I've had several people tell me their pets wake them up. They live by themselves. Had another, so the things at night can be, you wake up and you've had terrible nightmares. And they're very vivid dreams, like Technicolor, different from their usual dreams. They may wake up with a severe headache, and they may go back to bed, or they may get up and treat. So that's the other thing I want to know is that when you got up in the middle of the night, did you go get something to eat? So some people go to the bathroom and they make a circle around to the refrigerator to take a swig of juice and they go back to bed. So that's another, is to kind of discern, are you having symptoms at night, because they won't be like they have in the day, or are you eating in the middle of the night, or is this phenomenon what's happening? Have you ever had nighttime symptoms?
Yeah, I wake up really hot, and then that's when I go get a
So the sweating
Yeah.
wakes you up. Most of the time people wake up. Not all the time, but sometimes someone else is waking or some other disturbance. So do you keep something beside your bed?
No, but my kitchen isn't far.
So I usually tell people, keep something at your bedside, so that because you get impaired, when your sugars go down, your motor neurons do not function well. So keeping something that's easy to open, that you can easily get at, is something I advise. Questions about those? I can guarantee you I'll ask you something about that. I'm telling you, this is important things to ask, even of a type 2, whether they're on oral agents or a combination. It's important things to figure out, why are you high in the morning? In the daytime, it's pretty easy. I skip meal, we had birthday cake, I didn't take my meds. But at night, between the time they snack, after they eat, till the time they get up the next morning, it's a different life. Okay, so complications of insulin therapy. Hypoglycemia is number 1. This is another really important piece to know about. So identify patterns. So that's the first thing I'm asking. If they tell me in the last month I've had 2 lows, okay, when did they occur? I'm looking to see, did they occur at about the same time of the day? Because that tells me something about the medicine they're on or the meal that it's following. So hypoglycemia is most likely to occur under these circumstances. They skip a meal, they delay a meal, they don't eat as much at a meal as they usually do, they make a dosage error. What else did I put down? Increase their activity. Okay. I drill these home in patients. When you are designing an insulin regimen for somebody, whether they be type 1 or type 2, you're listening to what they're telling you, you're looking at the data that they're bringing in, but if they go off and do something differently, that's when hypoglycemia can occur. Okay? So always encouraging them, don't delay your meals. Don't skip a meal. Or if they're going to skip a meal, at least talk about, okay, here's what we're going to do. We're coming into Ramadan. Now you're going to fast all day long. Let's talk about what we're going to do differently. Okay. I work, my work is such that I never know where I'm going to eat. Okay, well, let's talk about how we're going to manage that. Those things need to be discussed and a plan made. Here's some examples I'll give you about activity. In the summertime, I see this the most on the day that the men mow the grass. Okay? Increased activity. Remember this, activity acts like insulin. Activity drives your blood sugars down even if insulin isn't present. Now, Michaela said one thing, this is what I wanted to capture that she made a comment on. So we want people to exercise. We want them to be active. But activity acts like insulin. And the more intense you do and the longer you do it, the longer it lasts. So after you exercise, your blood sugar can go low and stay low for 2 to 4 hours, or it can be 24 hours. So I've seen insulin sensors of top-notch athletes that are type 1. It's amazing what happens to them on the day that they work out and then the day that they don't. So what we want people to do, and she mentioned this, is before they exercise, we want to know what their blood sugars are. If they're above 250, what did I tell you a blood sugar of 250 meant in a type 1? Okay, 1 of 36 should know, have heard it. Pardon?
Is that one of the ketones?
Okay, so they don't have enough insulin. It's telling you, anytime a type 1 is running above 250, they are insulin deficient. Okay? So if they exercise, you have to have insulin around when you exercise. Those free fatty acids that you release, you got enough glycogen to go probably about 30 to 40 minutes. If you exceed that, then you're tapping into other tissues. Okay, so you've got to use free fatty acids when you have prolonged intense exercise. If you do not have enough insulin, guess what happens? Your blood sugar goes way up. So if somebody is 250 before they exercise, we tell them don't exercise, take some insulin, wait, and when your blood sugars come down, then you can exercise. Because if you exercise then, your blood sugar will go up. So we always tell patients, exercise is great, makes your blood sugar go down. Well, not all the time. It's above 250, it will go up. So one thing Michaela said is I like my blood sugar to be a little bit higher before I exercise. Not a bad approach. So if they're at 90 to 100, where they're normal, we would have them eat some carb before they exercised. Okay? We teach them this. We give them little handouts. Your blood sugar is this, eat this amount of carb, retest in so many minutes or hours. Okay? What she said she did, how high do you like it to get?
Like 160.
Okay, not bad. 160 to 200 is not bad, especially if you're going to be more intense. What kind of exercise do you do?
I just run.
Okay. That's a lot. So how do you run a certain amount before you reload or test?
I don't test until I'm done.
How long do you run?
Like 3 to 5 miles.
How long does it take you?
Depends on the day. Like 30 minutes to an hour.
Okay, 30 minutes is not bad. So have you ever gotten low in those last 30 minutes?
Yeah, I have, and I carry Starburst.
Okay,
But I don't test, I just feel it.
okay. Okay, so that's a really good example. So here we're going to wait. Here, this is good because she's going to use that fuel up. What's your blood sugar usually when you get done?
Like 90.
Yeah. Then do you eat more on the days that you run later in the day?
Yeah. Yes.
She has to because the effects of that are going to last for several hours. Her blood sugars will run much lower the rest of the day. So activity is really important. So activity is really, you have to count those in. So the reason I bring up those once a week things is because it's the unusual. So patients will go out, they'll cut the grass, and then they'll have a load. And they rarely have got something on them. So I always warn them, on the days that you're going to do unusual activity, then we need to have you eat an extra carb serving at lunch. Or lower your insulin. So I tell them to cut their insulin by a unit or two, depending on how much they're taking. Here was another one. I'll never forget this. This guy was funny. He was very quiet, older gentleman from the rural area. And I was seeing him for diabetes, and I noticed, I said, every Thursday you have a low. What are you doing? And he said, that's the day my wife makes me go to the mall and walk with her, so to shop. So they would spend 2 or 3 hours in the mall, and sure enough, he would get low because of all the walking. I have had patients that it's the day they go grocery shopping. They go to Walmart. Walmart is a big place, and they walk around, and sure enough, they'll get low at the end of the shopping experience. Okay? So I tell you these things to make you or remember that exercise is important. So when I say it can create a load, that's what happens. I've had more patients get in trouble by skipping or delaying a meal. Had a guy one time who was on his way to Guthrie. Thank goodness he had his grandson with him, and they were late to get up to Guthrie to eat lunch. Well, his grandfather had a low blood sugar in the car on the way to Guthrie. His 9-year-old grandson got out of the car and waved down a highway patrolman, and they got him treated. I see this happen a lot with on the way home. They're on the way home, they get stuck in traffic, something happens, they get delayed. So that's why we always tell people carry sugar source with you. And keep it in multiple places. Keep it on you. I tell people to keep it in their glove compartment, keep it somewhere in the car, where you're working, out in your shop, wherever you are, keep those sources out there so you can get to them quickly. Because low blood sugar will come on quickly, and it's sudden. So they will have a sudden onset of, I don't feel good. They'll usually have clusters of symptoms. They won't have everything. This lady's got I would say what most of the time I hear out of patients is it's a sudden onset, I'm weak, I've got to have something to eat. I've got to sit down, get sweaty, diaphoretic, shaky. The headaches can occur. The other things would be a heart will race, so they've got epinephrine that is surging through their body. So they may have that feeling of anxiety is another one. If they will treat at that point, then the symptoms will go away. They can self-manage. If they ignore it and do not get help, then the blood sugar will continue to drop, and when that happens, their brain is no longer getting enough. I'll get you just a second, Amy. So their blood sugar will drop enough that they can no longer think or walk or have motor function that's normal. So this is where I had several young men that got stopped for drunken driving. I had one kid that got thrown in jail for drunken driving, and it was a low blood sugar. They had a guy not too long ago in the last few months who died in one of the county jails because he was diabetic, told him he needed insulin, and they didn't get it, and he died. So motor-wise, it can mess you up. That slurred speech. Have you ever seen Steel Magnolias? Julia Roberts, that's a moderately severe. Her blood sugar is probably under 40. She was irritated, wasn't she? Got combative with her mother, so their personality usually will change. Irritable, combative, not themselves. Their gait will be off, can't walk. I was in the VA one day and I had a patient of mine, I saw him behind and he was going like this. And I said, Mr. So-and-so, what is wrong? And he started talking to me really weird. He was having a low. I've had several patients who have got arrested for public drunkenness that were having lows on out on the sidewalk. So that's kind of what it looks like. Okay, Amy and then Mariah.
I guess I don't completely understand what's causing that dip in blood sugar if they're not taking their, so is it if they skip a meal but they took their insulin, that's why?
Yes.
Okay,
yes,
so it's
yes.
not just skipping a meal and not doing insulin?
This is taking a glucose lowering agent
Okay.
and skipping a meal.
Okay.
Yes, sorry.
That's okay.
I thought it was intuitive, but thank you for pointing that out. Mariah?
So my grandpa, he was a farmer and he got pulled over in his tractor and then thrown into the county jail. How long do you have? Because my grandma was like, I don't have time to go pick them up. He's going to die.
Oh my gosh. So how long do you have?
Yeah, because he
Well-
was in the county jail and it's so far away to go there.
Yeah, well, you don't have long. You have sometimes hours. The young man that died, I think, was in there 2 days. I think.
They just thought he was drunk for 2
Uh-huh.
days.
I can tell you, I've had it happen to more patients.
Crazy.
Well, they ignore them.
Police.
They're just, there's nobody watching them.
Police officers don't treat
That's what I'm thinking. Get them
You don't have people
That happens
also
with asthma,
who
too.
are
Yeah.
trained,
Have you seen the night before?
and they may be dealing with people who are taking medications all the time. So it may not occur to them that this is a low. But this guy had said, I'm a diabetic and I need my insulin. So,
I was gonna say just in Oklahoma City, it's gotten so bad, like the D50 wake-ups or whatever, like diabetic wake-ups for
what is that?
INSTA.
What do you mean?
Like whenever they get called out, like 911 to wake somebody
And
up.
they call them a D50 wake up,
Yeah.
or they give them Dextro D50.
Yeah.
Okay.
But it's gotten so bad to the point where INSTA's figured out a way to bill insurance and bill them for that
No joke.
because they would just refuse being taken into the ER because you woke them up, they're fine, but they get called out so much. That's probably the most common call they get.
Wow. Wow. Hmm.
So people just don't take care of themselves, and then it's really bad.
You know, I have called the county jail before on the behalf of patients. I get a call from a family member that says, so-and-so's been thrown in jail, they won't give them any of their medicines, I need you to call. Well, it's taken me hours to wade through. Now, every judge I've gotten to has gone with it, but it has taken a while to get to that point. Other stories? I did not know that. That's interesting. Okay. So, Sophie, education in diabetes education goes over this. You also, as providers, always need to ask them. If they've had lows, it's like, okay, well, how did you treat it? and then correct it or do some education if they have not, or have whoever in your group is doing that education to reinforce that. And always ask them, what do you carry? What do you carry? Do you carry anything? You'll find a lot of patients don't carry anything for a low. I've never had one. My blood sugar is always high. You still gotta have something with you. So let's look at mild hypoglycemia. It's adrenergic symptoms. I can guarantee you, I'll probably give you a scenario on the test that gives you these symptoms and how would you respond? How would you treat? So adrenergic symptoms, so these are anxiety, sweating, tremulousness, tachycardia, hunger. They won't have all of them, they'll have a cluster of them. Clinically significant hypoglycemia is now defined as when your blood sugar drops below 54 milligrams per deciliter. Glucose alerts, like Michaela said, if they're wearing a watch or some type of glucose sensor or wearing one, then they recommend that alarm be set at 70, just like she has told you she does. Usually cognitive deficits are not acute at that point. They can self-recognize and they can self-manage. So what we need them to do is to take in about 10 to 15 grams of a quick-acting sugar. Candy bars do not count. This is probably the most common things patient will carry, but the fat in the candy bar will slow down the absorption of sugar. So we want something very quick. Milk, juice, regular soda. Diet soda will not work for you. Or it can be peppermint candy. It can be frosting, little tubes of frosting. The cheapest thing I have found to correct a low blood sugar is cocktail sugar cubes. You can buy 200 for 80 cents, or the last time I checked. So, and you're not tempted to munch on them. So you put 4 to 6 of them in a little baggy snack and carry it with you. A lot of my patients just lift sugar packets and honey packets from the restaurants. They work. But you got to carry it on you. And you have to have something. To me, honey packets are too hard to tear when you have a low. The sugar packets probably work better because they're just paper. So jelly beans, I like the jelly bean concept too, is if you can stay away from them. So I tell them, don't get something that you are tempted to eat. Buy something that you wouldn't normally eat. What I love at Halloween are those little 6 packets of Lifesavers. Those are good. Those are great. 6 of those, that's a perfect amount. Moderate hypoglycemia is adrenergic symptoms plus neuroglycopenic. So that's where the brain starts to be affected. Like I told you about the guy who was dragging his foot. These people are being thrown in jail for being inebriated. That's this level. People who are hypoglycemic unawareness this is where this is where it first shows up for them. Like Julia Roberts, that's where she was, is in this range. So mood change, irritability, confused thinking, slurred speech, very common. These folks need more treatment than the mild, and they may not recognize it, and they may be fairly resistant to you doing anything. So that 10 to 15 grams of a simple sugar form, that'll reverse most mild, and within 10 to 15 minutes their blood sugars will rise enough that if they are just mildly low, they can come out of it. So if you're at about 50 and you take 10 to 15 grams of those carbs, you will rise up to about 100. Now we usually want them to go ahead and eat, especially if it's, well, we want them to go ahead and eat anyway. Moderate, they may need 2 doses. So we wait 10 minutes, see if they come up. If they don't, we give them another dose. Usually they'll need a couple of treatments. Severe hypoglycemia, they are in danger of, they usually lose consciousness, and so they need like this dextrose 50 she's talking about, glucagon treatment, and that's a medical emergency because they can die from that. treating hypoglycemia with glucagon. So glucagon, you know, stimulates the liver to release sugar. So we can teach, and usually for children, Michaela said they taught her family members how to use glucagon. So at this point, it comes in this kit, and it's got a diluent in a syringe, and it has the lyophilized powder in the vial. So they shoot the liquid in the syringe into the vial, they mix it up, and then they pull it back out and give it. Okay, that's why you have to teach family members how to do it, because it's a little bit involved. This will usually raise blood sugar up enough that you can get give you time before medical emergency or emergency groups will get there. It will not totally correct a blood sugar. It buys you time. It's an acute thing you can do, but it will not bring them up and it won't sustain them out of a more moderate to severe low. I just saw where there is a product that has been approved. It's not on the market yet. It's called Locemia, and it is a nasal glucagon spray. So I think it's been approved. I could not find that it's marketed yet. So that would be great. That would be so much easier. And you could administer it to a person who's lost consciousness. The last time I checked, these things are expensive. The glucon, and this is why a lot of people don't keep them. They're about $100. Is that what you?
Yeah, and then you don't even use it, and then you have to rebuy it.
Yeah, that's the problem. It goes out of date and you have to rebuy it. So I don't find many people keep it. I've had a few, but. Okay. So on the next page, at the top of page 11, they'll call it the 15-15 rule. So 15 grams of carb, 15 minutes, and check the blood sugar. For patients that don't have lows very often, or I'm not sure they're having lows, if I can get them to check a blood sugar, if they can do it, I'd like to know where they are. So sometimes I get patients to do that. Sometimes they just can't do it for themselves. But I do encourage them to check their blood sugar after they've treated. It is very, very common for patients to overtreat. It does not feel good to have a low, and it scares them. So they often, what will happen is they'll have a low, and then they will way overtreat, and then you're dealing with 200, 300, 400s. So this is why it's important to revisit. How did you feel? What did you do? How did you treat? And to avoid that big rebound that then they have to feel with. Then they just feel like crap. So going over that is important. So there's some sources, the orange juice, apple juice, grape, it doesn't matter. As long as it's a juice that's got some sugar, and if it's a low content sugar juice, that doesn't really help. I usually tell patients keep it around the house. Get your little stores about where you keep them. I used to tell people just carry it on your body, but I've learned it's better if wherever they usually are, we have some kind of little sugar source secreted away. Let's see. There are commercial products. There's instant glucose, Dex4, BD glucose tablets, Monogel. They're fine. They're all okay. I think they're expensive, but if you want those products, you can. They work. They're great, but they're more expensive. I like cake frosting gel. It's easy to squirt in your mouth. The only thing is, can you get the top off? But if somebody's carrying it for somebody, I like that one as well. So I've given you the pictures of all those on the front. The other thing is, if they're carrying candy, make sure they haven't bought sugar-free candy. I've had that happen. Okay, so products that can stabilize your blood sugar and decrease the risk of lows. So can you imagine being a parent of a toddler and you are putting them to bed and you're like, what if they have a low? So they make these products, Nightbite, Extend-Bar. They were made by a pediatrician who's an endocrinologist. She's great. And they are designed for this very thing, is for eating it at night, and it releases sugar in a slow period over the nighttime. So Night Bite, let's see, and Extend Bar, those are the two I know about.
I've got a question.
Yeah.
Kind of more for Kaylee. Whenever you said that you had that alarm system and your dad could be hooked to it, could you use that for toddlers? Did he get like a buzzing noise?
Yeah, so I was telling her my dad is set up on my Dexcom sensor. Well, he was getting really annoying when I was going low, so I stopped him. I can see how it would be helpful for kids.
Uh-huh.
It would warn the parent that they were going low. They'd get like an alert on their phone.
Yeah, the technology is just becoming amazing. Yeah, that would work. The other is that we put them to bed a little bit higher in blood sugar wise to make sure it's up maybe a 150 or more, 150, 160 before they go to bed. Dermatologic adverse effects, we talked about these yesterday. So the lipoatrophy and lipohypertrophy. Again, these are dermatologic side effects due to where people are injecting and how frequently. So what these go to is rotate your sites. Rotate, even if you just use abdomen, using rotating sites. For most type 2s, I like the abdomen. It's that most of the people don't exercise it, so I have to worry about muscles. There's usually enough fat there. It's usually big enough in my type 2s that they can have adequate space to inject. So I usually teach them to kind of use the navel as the midpoint of their clock, and then just move it around the face of a clock in terms of rotating sites. If you've got thinner people that are injecting, especially like in an arm or a leg, you've got to be careful about if they're going to exercise it. So skin thickness, the amount of subcutaneous fat in the area, if they're going to exercise, or if they're very active at work, that can speed up and increase the absorption of that insulin, then get low. Here's what happened to one man I took care of. He would inject every morning in his leg. He didn't like to use his belly, so he used his leg. But he would go to work, and he was like the foreman of I can't remember now, like maybe it was like a restaurant or something along that line. But he did a lot of mopping, cleaning, moving from 7 o'clock in the morning till 10. Well, at 10, he was having profound lows. And a lot of it was because where he was injecting, he was eating adequately, but those lows were coming, one because of his activity, but the other is that I think he was injecting and then exercising that muscle. And so he ended up with lows because of that. So if people are going to, like if you were going to run, don't inject into your leg. She'd want to inject into her belly. It's less likely to increase blood flow and get more absorption. So that is important where they choose to inject. Systemic allergies, very rare. I think in all my years, 30 years, I have seen maybe one anaphylactic serious reaction to insulin. When that happens, they do a rapid desensitization. They desensitize that person to insulin in 12 hours. So usually you got specialists who will do that, but so that's very rare. What is more common is that people will get a new vial or a new pen of a different insulin. So Zane, you were talking about that woman who had to switch to a different insulin from Humalog to Novolog. Okay, so this is when this might occur. They inject and all of a sudden they get a reaction at that site. So it gets warm, red, itchy. Usually, those will go away after the first pen or vial has been used. You can use local treatment. You could give them an antihistamine. It's usually not necessary. You can do just topical treatment. But as long as it's local only, no systemic side effects, usually we just have them treat through it. And after they've used it for a few days, that usually goes away. So that's a local reaction. Okay, for kiddos and adolescents. I admire the people who take care of kids with type 1. I have several friends that are that do this, and I'm just in awe of them. Because with children, it's a constant change. So as they grow, their insulin sensitivities change. When they hit puberty, it's a whole different thing. Their social aspects are very different. You're having to deal with parents that bring their own issues into the care of the patient. You have developmental stages that they are going through. You have to look at when you're eventually wanting to move that child to independence. So sometimes it's hard for parents to let go of that. And so when can they start injecting their own insulin? When can they do it independently without you watching? When can they start doing their blood sugars and keeping a log and going in to see the doctor by themselves? All those issues they have to deal with. The food and the rebellion during the teenage years is really difficult. So that's why it's so important to get those folks, if you have a child that you diagnose with type 1, get them into a program that is geared for that, because they know how to deal with it. They'll almost always have psychologists or behavioral therapists that work with them. They'll have support groups. They'll have nurse educators. They'll have dietitians that are working with them. They are amazing. And they have really good relationships with their patients. So the very last page of this talks about transition. So one of the hardest things, Michaela's lucky in that she was diagnosed more of what we consider an adult. Because the hardest thing that patients have, that children and teenagers, when they move from, they graduate, go off to college, or they get a job or go into trade school, is the transition from pediatric care, cozy, everybody knows your name, you've known them all your life, and now you go to the sterile adult world of medicine. And most kids drop out. It's very hard. So the endocrinologists, both pediatric and adult, have made a concerted effort over the last 10 years to develop transitions of care. There are some pediatricians now, or an adult endocrinologists, that have geared their practice just for those transition years. So the 20s, and helping these folks transition to a more adult care. It's really difficult. A lot of kids that have been on Medicaid and now turn 18, and that's it. They're out of foster care, or they're out on their own. Most of them drop out. I've seen a lot of them show up at family medicine, and they got put in the hospital because they ran out of insulin, or they've been buying it here and there, and they just kind of kept themselves under the radar until they crash and burn, and then they end up in somebody's hospital or somebody's clinic. So that's really a tough time. So if you are dealing with kids that are new to your practice, be aware of that. It's really different from them. It looks different. So that's one thing to keep in mind with adolescents going to adults. With children, if you look down under B, glycemic control under children is defined differently than adults, and I want you to know those. Okay. So across the board for the A1C, they just changed this in the last year. The A1C for kids is less than 7.5%. So a little bit higher. They do fine. It doesn't put them at higher risk for complications. Keeps them from having lows more often. 90 to 130 before a meal. 90 to 150 at bedtime or overnight. So a little bit higher levels than what we use for adults. Because type 1 is an autoimmune disease, and because other autoimmune diseases commonly occur together, it is recommended that all people diagnosed with type 1 be screened for thyroid disease. Same time, or very soon thereafter. The other is to watch out for celiac disease. It's much, much more common in the type 1 population. It is not as easily diagnosed, so they have to do, what is it? They do tissue transglutamase or deaminated gliadin antibodies with a normal IgA. So usually you're looking for symptoms, failure to thrive. Those usually will be when you refer those people or get those levels. So we don't screen everybody for celiac, but you need to have a high sensitivity for it in case those symptoms show up. And then work them up for that disease. Does that make sense? Because it requires a biopsy, you probably need a GI doc involved or an immune specialist as well. So cardiovascular disease, so what do we do with kids? Well, we want to get their blood pressures. We want to screen for lipids. If you have to use a drug, use a statin in kids. Goal of therapy is an LDL of less than 100. Talk to them about smoking cessation. Talk to them about don't start smoking. Now it's more common for them to vape instead of smoke. So smoking, cigarette smoking has actually gone down in teenage, but the vaping has gone way up. Screening for complications. So I'm going to hit this again when we do chronic complication discussion. So we're going to screen the urine for albuminuria, so protein in the urine, after they've had the disease at least 5 years. Usually that starts at age 10. We don't do it if they're 2, and we don't screen them at 7. We wait till they're past usually puberty. If they need treatment, we use an ACE inhibitor. Again, the same things that are going to help adults, normalize blood pressure, normalize glucose, will be used. We're going to screen for retinopathy at age 10 or after puberty, whichever is first, once the child's had diabetes for 3 to 5 years. Okay. So with adults, it's going to have a very different recommendation. So here, the delay in complications, we have a delay time in time to screen. Questions? Okay, let's take a break.